1440 KVON 99.3 The Vine. This is Kelly. It is time for Healthy Communities with St. Helena Hospital. This morning, I have a neuro-ophthalmologist. I get all these really amazing people in my studio. This morning, Dr. Robert Egan. Good morning.
Good morning.
It's great to have you here.
Thank you for having me.
I can honestly say I've never spoken with a neuro-ophthalmologist. I bet a lot of our listeners haven't either. So this is a great opportunity. So what is a neuro-ophthalmologist?
Well, a neuro-ophthalmologist is a physician who sees patients who have neurologic disorders that affect vision. And so there are a number of conditions that can affect your vision, such as stroke, multiple sclerosis, brain tumors, as well as processes that affect the eye directly.
So this is not I wouldn't go to you just because I need glasses.
Correct.
Because I don't have very good vision.
Correct.
You're going to get more detailed, more complicated
Exactly.
cases. Okay. Well, talk about some of these diseases that you treat, and maybe a little bit about symptoms people can look for, or the people referred to you by their doctor.
Well, the typical symptoms that patients will have would be vision loss in one eye or both eyes, visual loss even just to one side that may be present in both eyes, as well as double vision.
And so they would probably go to their eye doctor, who would then refer to you. I mean, how do they know when they need to get to you?
Typically, they go to the regular eye doctor first, and then they identify that they have a problem that is actually neurologic in origin, and then the patient gets referred to me.
All right. And so talk about this big discovery that you and Dr. Pomerantz made. You identified the association between Viagra and vision loss. I've never heard of this.
Well, about 10 years ago, it seemed to be the biggest thing in the news, and everybody was talking about it. And there was even a comment about it in a Robin Williams movie where he made a joke about Viagra and vision loss.
Oh, no. So you were one of the ones that actually discovered that.
Correct. When I was doing my training at Harvard, I saw a patient that was seen by Dr. Pomerantz, who was training the year before me. So I had seen this patient that he had seen first, who had a stroke in his optic nerve. And the patient had come in and told me, this was 9 months after he had been initially diagnosed, he told me, "Well, now that I'm here without my girlfriend, I'd like to tell you the rest of the story."
Oh my word.
And so I knew that he was going to tell me something juicy, and he had told me that his vision loss had occurred roughly about 30 minutes after taking a pill of Viagra, a very standard dose of Viagra, and he had lost vision that was permanent in his eye.
Now, what kind of vision loss? Like complete, like he was eye went completely black, or?
It was partial vision loss, so he could not see down from center in one of his eyes.
Oh my! And it was permanent?
Permanent.
So what did you do?
Well, when I saw that, obviously there wasn't really anything that I could do for the patient, gentleman at that time, but the one thing that I did do was I decided I wanted to make it known in the medical literature, and so I called Dr. Pomerantz. He and I know each other very well because we trained together very briefly, and we wrote up the paper. And it was published in Archives of Ophthalmology, and then since then I've written a number of editorials, and then got interviewed on the Wall Street Journal and the Men's Fitness magazine, and been on local TV because of this, and it gave me my 15 minutes of fame.
Now you're on Kelly in the Morning. So, well, did they ever find a way to counteract that? Does it only happen in certain people?
Well, patients who develop this specific problem, the condition is really only seen in patients who have a specific shape to their optic nerve. And so if you don't have that shape to your optic nerve, it's rather protective against that problem. So when we see patients who have this problem, or if we see a patient who has suffered the problem that was not associated with Viagra, because it can occur without Viagra or Cialis or Levitra, that we recommend patients do not take either one of those or any of those drugs, because it could cause the second eye to become involved.
So is this something that if, and I know this is not, you don't prescribe those drugs, but is this something that they check for before they'll give that prescription now? They'll check the shape of the eye?
Actually,
screen them? No?
To date, I don't know exactly how many patients have actually suffered this type of vision loss from Viagra, because I don't think that it's really being reported anymore. But I don't think it's a huge number of patients. And with the number of prescriptions of these medications, which is in the tens of millions, that the risk of vision loss is still very, very low. Okay. I don't think people should be rushing to their pharmacy or rushing to their cabinet right now and throwing out all their Viagra, Cialis, and Levitra.
That could cause a problem.
But if they've suffered any vision loss prior, they probably want to go to the eye doctor first before taking more of it.
Right. Oh, that's a good point. So you also did some work with stroke victims and learning more about the eyes and stroke. And I know I'm not using the right terminology, but talk a little bit about that.
I did extra training after my neurology residency in stroke, and one of the plans is working on a stroke center at St. Helena Hospital. I came from a very busy stroke center at Oregon Health and Science University, where we would run to multiple hospitals giving a clot-busting drug very shortly after patients had suffered their stroke to try to treat their strokes. We're doing that at St. Helena Hospital, and I've really changed the practices of ER physicians and treating physicians in this area, because now TPA is given very frequently when it was not given at all before I came.
Now, I know, is this the same thing? Because I've heard that before. I remember a few years ago they started saying, there was a time when they said if someone had a stroke, there's not much you can do. And then they started saying, get someone to the ER as fast as you can because time is of the essence. Is that for this drug?
Yes, it is. The medication is, the abbreviation is TPA, which stands for Tissue Plasminogen Activator. It needs to be given within 4.5 hours of onset of the stroke. So patients, they can't just sit home and hopefully think that it's going to get better. The difference between stroke in the brain and essentially stroke in the heart, which is a heart attack, is that heart attacks are painful. So when a patient is sitting home and their chest is hurting, they call 911 and they go to the hospital right away, and that's why so many people are helped and saved from their heart attacks. But many patients, if they have a stroke in the brain, it's painless, and a lot of them will sit home and wait till the next morning and realize, I still have my paralysis, and I guess I'll go to the ER now, and now it's too late.
Is that the primary symptom? They're like, I've heard that they have paralysis on one side.
Well, there have been a lot of promotional, marketing techniques that have been thrown out for stroke, and depending on where you look, there are pretty much 4 or 5 symptoms that people are really sort of pushing to the general public that they look for. One is vision. So vision loss that is sudden in one or both eyes should make a person think that it's possible that they had a stroke.
The other is be blurry vision, double vision, going completely blind. Any of the above?
Correct.
Okay.
The other is problems in speech. So if your speech suddenly slurs fairly significantly, or you're not making sense when you're talking, you or people around you should take you to the ER immediately. The other is partial or full paralysis on one side of your body, or an acute onset of difficulty walking. So these should all be warning signs of stroke and should prompt a person to go to the emergency room immediately, because waiting longer than 4.5 hours could lead to permanent brain damage that cannot be reversed.
And is there a particular type of person that might be more predisposed to a stroke of this nature?
Well, we know that stroke risk factors include high blood pressure, diabetes, high cholesterol, and smoking. And probably the single most important risk factor a person can change to reduce the risk of stroke in the future is by stopping smoking. Other things, specific types of heart diseases, especially abnormal heart rhythms, a term that many people know, which is atrial fibrillation, is a huge risk factor for stroke. And so these things can all be done to help prevent strokes in the future.
Oh, that's great information. Well, Dr. Robert Egan, how can we contact you?
My office number is obviously 707 area code 963-1882. And I have an office at St. Helena Hospital as well as at the Napa Eye Care Center in Napa.
And there's a website you can check, sthelenahospitals.org, our own St. Helena Hospital. Thank you so much for being with us this morning.
You're welcome.
It's Healthy Communities, brought to you by St. Helena Hospital. That's sthelenahospitals.org. And Dr. Egan, I have a song for you. Here we go.